So welcome everyone who has joined us. We're so glad you could be here for this session. And we are going to kick it off with an introduction of Carmen Hughes. My name is Phoebe Nelms. I was on earlier in the symposium. And leading this discussion, moderating this discussion with our two wonderful partners is the director of the Health IT Division here at Morehouse School of Medicine, Mrs. Carmen Hughes. Carmen?
Fantastic. Thank you, Phoebe. Phoebe, and good afternoon to everyone. I am thrilled to facilitate this breakout session with two industry leaders who have been working in this field of after-visit care for many years. I am Carmen Hughes, as Phoebe mentioned, the Executive Director of the Health IT Division here at the National Center for Primary Care at Morehouse School of Medicine. Just one stop, Michelle, I think we're seeing your note screen. But it is my honor to bring you information in real life scenarios supporting patients after their visits for equitable, let me say it again, supporting patients after their visits promotes equitable outcomes. And that's what we will focus on today. And during this session, you will learn how patient monitoring and follow-up communications are really vital to identifying and addressing the needs that promote equity and health outcomes. So first, for those of you who are maybe not familiar with Hybrid Solution, you may also know us as Georgia High Tech. We were formed as the only regional extension center here in Georgia. We were funded by the Office of National Coordinator, ONC, in 2009 to help Georgia clinicians transfer from paper records to electronic health record technology. And through this effort, we did support or have supported over 5,000 eligible clinicians, 50 critical access and rural hospitals through various educations and outreach activities. And we've had nearly 3,000 successful attestations over the life of the Meaningful Use program outcomes. So we continue this work in the digital health space and health IT as Georgia's Health IT Center for assisting clinicians in the redesign of healthcare delivery through the successful adoption, continued adoption, and utilization of EHR technology. We also support providers in healthcare delivery and meeting the requirements of MACRA's Quality Payment Program, or MIPS, and other quality care and value-based programs. We additionally serve as a health information exchange to GHIN as a node on the Georgia Health Information Network, which is also the state designated network. And through this platform, we have various query-based exchange products for providing clinical data and records to clinicians at the point of care. So really, we like to say that our goal is to optimize patient information management through technologies for the successful transition to value-based clinical models and better health outcomes. So as I mentioned, we have two exciting industry leaders who I've had the good fortune of partnering with for many years in the work we do at Highbridge, and extending really back to our times when we were the Regional Extension Center. So both Premedics and Synsormed play a vital role in our success by providing call center support, serving as a direct link to our members and providers and their patients through education and outreach, and also subject matter experts and advisors related to post-visit and follow-up patient care. Both really absolutely understand the importance and the mission of equitable healthcare to all. So I just want to mention, we've structured this session to be interactive for each of you. We have a few poll questions that are going to come up after we hear from our panelists, and we want you to be engaged. And of course, feel free to post any questions in the chat. So let's jump right in. I'd like to turn it over to Amin Holmes to share a little more about himself and the great work that he has seen through the lens of his company, Synsormed. Amin, the floor is yours.
Thanks, Carmen. I appreciate it. Thank you for inviting me. I'm glad to be here. And I'll get started. I have a few slides here that we can go over to talk about health equity and remote monitoring. So again, my name is Amin Holmes. I am a co-founder and president of Synsormed Incorporated, where we help patients get better at home. So I'll go through some high level things and kind of keep it short because we do want to have a lot of the time open for interactive, feedback and kind of get to the meat of what the audience wants to hear about. So I'll go through my slides for Synsormed. So what we have here is, so I just like to start off with some definitions here about what is equitable, fair and impartial health outcomes for everyone. So that's generally what we're talking about when we say make things equitable. And let's just move back. Sorry. There we go. Okay. So I like to think of it as like a progression. So traditionally, and I kind of, made it kind of a more laid back terminology, but it's traditionally, I think our healthcare, the way I would say it personally is, we'll see you when you get sick. So, you send you out the door, come back, when you need help, when you're having a bad time, when you're having exasperation. Home health is a little bit closer. It says, okay, we'll send somebody to your house to check on you. And, periodically, once a week, once a month, depends on, how often. Telehealth, especially in remote monitoring, it's kind of like a check on yourself and we'll keep an eye on you. It allows with technology these days, with the internet, the pervasive nature of 5G technologies, you're able to have a patient take care of themselves, and then they're able to transmit that information securely and efficiently to medical professionals anywhere in the world. So that's kind of where we've gotten to, and we're trying to be more proactive with patients' care so that we can help lower the cost and kind of bend that cost curve and keep patients healthier longer. Okay, so how do we do that? One way is with remote patient monitoring. So here you see a few devices. So this is remote patient monitoring is big on devices. So we ship blood pressure cuffs, pulse oximeters, scales, glucometers to patients all over the country so that they can use those devices and send the information to their provider or nurse that's actually monitoring their information and checking for inconsistencies, checking for things that are elevated, and then taking action based on different protocols. We also support remote therapeutic monitoring, which is kind of like a cousin to remote patient monitoring. It's a little more flexible on the device side, but it is currently from a CPT code standpoint limited to respiratory therapy and musculoskeletal type of therapy. So that's why you see here the pulse ox, the inhalers, as well as the physical therapy options. So that is another, they just started in this for being reimbursable just this January. So it's fresh, and we're getting more and more practices, making them aware of it so that they can offer these services to their patients. Okay, real high level, quick, I won't go into detail, but just give you a sense of how does this work, remote patient monitoring. So essentially you have to choose the patient. There's a recruiting step that has to happen. So you choose the patient, get their consent. Consent is required. And so they know everything that's going on about the program, why were they chosen, what are their goals, if they're going to owe anything, co-pays or anything, kind of get that up and have their consent. Once they're signed onto the program, then the deployment needs to happen. So this is the device part. So someone has to either put the device in their hand or we may ship the device to them. Then last but not least, well, we have to go on to do the analysis. Now that we have the data, a medical professional has to look at it and make a determination if there's some escalation that's needed. And then we finish with billing. So now that those services are provided, there needs to be a way to aggregate that information so that the billing department can submit for reimbursement. Why are we doing this? So this is a study we did with Navicent Healthcare in Middle Georgia around COPD patients and how it affected their readmission rates. So it turned out very good with the cohort that we worked with, and drastically reduced their overall readmission rates by having them answer a series of questions related to their smoking, to their inhaler use, and making sure that their health is on the forefront of their mind. Quick blurb about the reimbursement part. There are CPT codes that do allow you to get reimbursed for remote patient monitoring. So that's been the big kick in the industry meaning a lot of interest has been generated around these codes, because now it's to the benefit of the practice to actually track these patients when they leave the office. One example is technology setup, reimbursement, the time for reviewing. So this just gives you a quick snapshot of what it could be like for a practice. Additional streams of revenue for practices offering these new services for their patient base. A high-level look of the type of metrics that we provide back to practices about their compliance numbers, a potential reimbursement versus actual reimbursement, and the like. And that's it. So I wanted to just give you guys a quick overview again, so we can get more to the Q&A and the polls. So I'll turn it over to Van, and I'll let you talk a little more about Premedics.
All right, great. Thanks, Amin. Great info there, and very complimentary to what we do at Premedex. So Carmen, thanks to you and Phoebe for inviting us to participate here as well in our partnership. We certainly appreciate it, and definitely great timing on this symposium here. It's front of mind everywhere, and so we're glad to be part of the many teams out across America to hopefully rise and meet the challenge as we look to improve healthcare for all. So Premedics, as Carmen mentioned in the intro, we're a tech-enabled service company, and we have call center technologies as well as automated technologies to reach out to patients and really collect data in between office visits and hospitalizations to understand how they're really doing. So if you think about the time that a patient spends with their provider each year, it's minimal. So what's really going on in their homes and their other care settings that they may be part of, and we want to understand how they're doing. So we use nurses to reach out and assess patients. We use automated phone calls, we use text messages, and we use other apps to collect this data. And then we have scripting and protocols to how we can establish intervention opportunities. How can we get the patient the resources they need that we've identified that they don't have, as an example. So a lot of our programs are developed around transitional care and readmission management and proactive or preventive measures as well. And essentially we've built these modules, as we call them, on top of a CRM platform in order to determine what's next in the patient life cycle as they move through managing their personal care. So of course, we try to be a technology company to gain efficiencies, but at the end of the day, we also understand that healthcare is human. And that's where we work with companies like Synsormed to help monitor these patients and take action when there is an alert, understanding that our busy medical professionals are already extremely covered up with reacting to those patients who are in needs, as Amin's slide indicated, coming in because I'm sick right now. So how do we move to the proactive, preventive outreach? Amin's tools do that, throws off data. So we are good at taking action on that data to supplement the provider teams that, again, are already extremely busy. Some of the programs that mirror Amin's, we can run through inpatient, and a little bit of background on Premedics. We are Atlanta-based. We work with customers across the country, but about 10 years ago, we did a study on what happens for a patient when they're discharged from the hospital. And at that time, the answer was, well, not much. It's really the patient left to fend for themselves and hopefully follow their discharge instructions. Over the last 10 years, healthcare has certainly become increasingly complex through payer plans and other obstacles that are in the way. So we feel like reinforcement and additional care navigation is essential at this critical time. If someone's been in the hospital, in all likelihood, short of giving birth to a child, it's for an event in their life that is not good. So we're thrilled to have the challenge to intersect with a human being at the time that they've just had an event in their life where we could help them and potentially influence them into a positive direction. But many people may not have the resources or the knowledge, simple knowledge in this complex healthcare to know where to go next. So we're really there to try to bridge that gap after that crucial event has occurred. Where does this patient need to go next? What do they need that they may not have? Or what do they need that they may not know they need? So typically a hospital will deliver us patients. And so you're seeing the data source across the top. Patients flow over to the Premedics platform, and we use some data characteristics in the files to essentially put the patient on a pathway. Are they pretty doing okay with a routine surgery, or do they have high acuity and multiple comorbidities? Maybe they have CHF, they have COPD, et cetera. So we can custom tailor the communication, the cadence or frequency, as well as the messaging to these patients as they come out of the hospital, tie in other tools as well, in addition to our nurse assessment, such as the remote patient monitoring tools. So really, how do we collect comprehensive data and intervene with this patient or these patients in order to provide the best possible health outcomes? Traditionally, these programs have been geared through case management teams to only the highest acuity patients coming out of the hospital. And traditionally also, the case management teams are relatively small when you look at ratios to number of discharges to number of case managers. And what we want to provide is transitional care for all. So how do we touch more patients coming out of the hospital, not those that are on the highest acuity level, but those that are mid-tier as well, to prevent them from moving into the highest acuity scale. So what we bring is a platform and the bandwidth to reach more patients and serve as a seamless extension to the teams within the provider facilities and or payer facilities. And so engaging more patients, enhancing the workflow so we can understand how patients are doing in more real time is essential. We can track them for different periods of time. Perhaps the lower acuity patients have 1 or 2 touch points after their hospitalizations. Others may need to be tracked for 30, 60, 90 days. And other high acuity, multiple comorbidity patients may be needing to be tracked for their entire duration, so year after year, as we try to keep them on track. So our assessments focus on what are typically strategic priorities within the facilities themselves, which is safety and quality is always a high priority there. They want to reduce unexpected readmissions, make sure that patients are taking their meds correct and have as close to zero med errors as possible. They also have a big focus on service, so we can help supplement that, giving the patient the care beyond the front door of the hospital, as we say. There's also many value-based programs out there that are shifting more towards outcome reimbursement compared to just fee-for-service reimbursement. Here are a couple of stats just to give you the sheer bandwidth that we can provide to help support patient communication. In the upper left, you can see where this one health system sent us about 78,000 patients in a single year to outreach. This is a 5-hospital system in the Mid-Atlantic region of the country. And you can see that typically we're driving somewhere around that 65 to 75% mark in connectivity rate with these patients once they've been discharged in the upper right. And then what's interesting is we're in a very mobile, busy society, needless to say. And how do you really connect with these patients can be challenging to get them compliant and to get information and help educate them. The lower left shows for the roughly 50,000 patients that we connected with, it took us 151,000 efforts. So about 3 times to reach each patient. And then we also do some other data hygiene for our clients, wrong numbers and other data cleanup to help them in a number of other aspects of their business. And in the lower right corner, this is really where the rubber meets the road. And the reason that we're trying to cast a net over every patient counts, as we say, but who's got an issue that we can uncover that may not have been identified while they were in the hospital, or may have occurred once they left the hospital. So these are what we call escalations. And we want to uncover these because these can certainly improve the patient's outcome, prevent the readmission. And we think everyone deserves this additional time once they're discharged to help them navigate the system. So we typically, when we gather the interventions and the escalation responses, we bucket them, and you see these in the horizontal columns here. Some of those are more service related. It's data that we just pick up through conversations and data that's captured from the patient via text or through nurse conversations. But the ones marked in red are really important to the outcome. And that's where we have a big focus. So understanding those discharge instructions. Can the patient read? Do we need somebody to further explain them? The discharge instructions. So we're very focused there. Medications. So we're typically reinforcing the importance to take the medication. We also, no hospital has a good record keeping of within the first 24 to 48 hours of whether their patients actually picked up their medications that were prescribed for them. So we find that information out in real time. And then also, do you understand how to take the medications? And if you didn't get the medications, why did you not get them? And so we deliver all of this data back so we can create solutions on the front end. So is it affordability is why they don't go get the medications? Are the doctors prescribing things that aren't available in the local pharmacies? Do they not have transportation to go pick up their meds, et cetera? And so we'll typically gather the data, then we'll build the solution around it. So frequently we're working with social services, care managers, et cetera, to find prescription cards, rebate cards, et cetera, to solve some of these problems. And as we gather more and more data, we can build more and more robust solutions with the health plan partner or health system partner. And then a big part of it's around plan of care as well. So what do they need to be doing and next, et cetera. We'll also, of course, check on their symptom management. But you can see these numbers in these columns. These are key areas. And there's really, when you break out the escalations, there's really a lot of activity in these. So I think about my dad as a great case study. When he goes to the hospital, he's 88 years old. Rarely does he ask any questions on his way out. He's ready to go home. And by the time he gets home, he's thinking, why didn't I ask? Am I supposed to stop that medication I was on because I got this new medication while I was in? When do I resume, et cetera? So really helping connect and reinforce is extremely important for everybody. This is a case study on readmissions. Again, that's in the crosshairs for most of our client healthcare health system clients who are looking to improve outcomes and reduce avoidable or unplanned readmissions. And so what we can do is we can put patients on our avoidable readmission program, again, that will drive the frequency of communication, the channel of communication. Is it a nurse call? Is it a pharmacist call? Is it a text message? Is it all three? And over how long do these programs occur? And so on the right side, you're seeing we're looking, medications are a big deal. Understanding, do they take them? Do they get them, take them correctly, et cetera? So that's something that we're constantly looking for. We've got it supplemented by nurse and other data gathering. And then we really want to understand about that patient, their social determinants, and create awareness to what they have or what they don't have, and can we fill that? And in those crosshairs, if we can do those three things correctly, we can really help reduce the unplanned readmission. And our stats over on the upper left show where we can take typically a double digit, not uncommon to see these numbers in the high teens or low 20s. And if we really embrace the patient on a regular basis, using our nurse teams, using remote tools like Synsormed to have constant data flow so we can proactively say, hey, patient, I see you're not doing well. You gained 10 pounds in the last few days. I need to talk with you, and we may need to get you into the office, but we're going to do that before your hospitalization. So great results. We're typically driving these numbers down into the single digits for avoidable readmission, which takes a lot of effort, but it's very rewarding to see the improved outcomes and hopefully the healthier lifestyle that we can turn some patients onto. So as the bullet points indicate, we want not just transitions of care for a few, but we want them for good transitions of care support for all, because every patient does count, and to drive these results across all patients. So hopefully this was helpful. We're glad again to be on the call today and learn more. So with that, I'll kick it back over.
Thanks, Van. And you touched a lot of the points that I want to make sure that we got out today. And I mean, thanks for your information. I think that as we think about post-visit care and the importance of post-visit care, you're right on track, making sure that patients are monitored, the importance of post-visit and aftercare. There's certainly benefit, and the goal is for patient wellness through the process and making sure to track patients. But that's also good to know, that there's financial incentives and there's dollars associated with that aftercare too, to help with supporting that care financially in the practice. So I'm going to stop there. I know our time is short, and I really want to make this interactive with our audience. So Michelle, I'm going to ask you to kick the first poll question up, and if we can start there. I want to sort of use that as a springboard of activity and conversation. So the first poll question, and it's the only one that has sort of a right or wrong answer. The other ones are more subjective. But what percentage of a patient's health outcome is determined by what happens outside of an office visit with their healthcare provider? So that's what we're talking about. Patients go home, how are they being monitored? What would you all say? And each of you, I hope that you will answer, and the poll is open. What percentage of health outcomes is determined by what happens after the visit with their healthcare provider? Michelle, do we have a good number?
We have 8 people that have answered. So maybe a couple
50%.
more. There we go. We're getting there.
We're getting there. Okay. Great. And it might be subjective too, but there is some literature out there. Excellent. Excellent. So I'm glad to know everyone believes there is some help there, and there's some importance of after visit care. So I just want to say that research has shown, and we pulled some data, that 80 to 90% of health is determined by the non-medical factors, as we know, such as the social determinants, smoking and access to healthy food and housing and transportation. All of those are known as health drivers, right? And so that has a great impact. So as Van and Amin, through their organizations and others, are going out and finding information or contacting patients, you're learning, are they taking their meds? But really, maybe they can't get that healthy food that they really need for their dietary restrictions or whatever the case may be. So
Yeah,
I think that's so important. So Amin, please tell me what you're seeing in this.
Yeah, you're so right. I personally think this question is the cornerstone of where we are in healthcare in the U.S. is we're finally starting to realize that just showing up to the office is not enough. Showing up to the doctor's appointment is not enough. Going to the ED is not enough. So this is not what's actually going to keep people healthy. So because as the statistic shows, over 80% of the health is determined by what happens between the visits and how well you take care of yourself, or that you take your medicine. So I think, so I guess on the macro level, we call this value-based care, right? So that's the big wave that you're trying to go through now. So And I'm a big believer in it, of course. Otherwise, we wouldn't have found the Synsormed. But it's, I think that's the only way as a country we're going to get there by really by empowering patients to take care of themselves and be more mindful. And it is a mindset. I do believe it is a mindset that many people may think, okay, I can do whatever I want to do in between the visits, and then the doctor will fix me. Or I can go to the hospital and they'll fix me. So, but if you didn't want to go to the hospital in the first place, you may want to take a note of what you're doing in between the visits. And so that's one of the things that Synsormed and Premedics help with, to touch those patients and keep in contact with them to deal in that 80-90% range.
Yeah. Yeah, I'd echo those thoughts too. And yeah, the macro of value-based care is interesting. And I think the term that I hear a lot that makes a lot of sense, or the saying that I hear a lot, is you took your car into the shop to get the knock fixed under the hood, you pay for it, and then you drive it off the lot and it's knocking, you turn around, come back into the parking lot, and you say it's still knocking, it wasn't fixed. Well, that was the analogy that was used by CMS when the readmission penalties were put into play. And a lot of people don't fully understand that or aren't aware of it, but it was really the drive to make sure that patient is well. And we also see the provider side that, hey, that's not exactly fair for you as providers either. But the light bulb is going off that, gosh, I've got to understand what's going on with them when they walk out the front door, or I'm held accountable now, and it's going to drive the way that we are paid in the future. So and ultimately that's there's a balancing act there. It's the right thing for the patient too. And I've got a great personal experience that happened exactly with my father when those exact penalties were being rolled out. So reinforcing information, understanding what's happening with that patient once they arrive back home, instead of gather in between office visits and hospitalizations, key to the future for value-based care.
Absolutely. Thank you for that. And you're right on point, but you both. And so I think as we want to launch the next poll question, because I think it feeds right into, as we talk about after visit care, what first comes to mind when you think about remote patient monitoring? And again, this one might be a little bit more subjective. It helps patients to be more engaged in their care. It's too hard to incorporate into a practice. It is a great tool to manage chronic conditions, and I'm not sure I need more information. You might have more than one, but what's top of mind for you? Michelle, what'd you think? Do you think we're ready to look to see what our results are? Is everyone in? There it is. Oh, okay. We have a great split, actually. So that makes for some great conversation. It helps patients be more engaged. It's well, actually, no, it's middle, which 33% is too hard to incorporate, 25%. It's a great tool to manage chronic conditions, 42%. So I'm sure if there was a secondary aspect to this question, we might get all 100%. It's a great tool to manage chronic conditions. And then, maybe a certain percentage that maybe says too hard to incorporate into a practice. So I think that would be a great discussion point. And again, if you have questions around these, please feel free to put them in the chat. So Van, do you want to take that one on? And then
sure,
and we just have about 10 minutes, so we
okay.
Make sure we get them
I'll
all
be
in.
quick here. Yes, but I'm not surprised by these results being split like this. But yeah, certainly a great tool to manage chronic conditions. It's what it's all about, understanding what these patients need and what's going on in their lives outside that brief office visit, if assuming we can get them to those office visits or that hospitalization. And I think I'll throw one more topic out there before Amin jumps in, but one thing I like to say is what is remote patient monitoring? We consider remote patient monitoring to be two things related to Premedics. There's deviceless. So we're talking with patients using nurses and assessments, chronic care management templates, and there's device. And together it's extremely robust. 8 years ago, when we're assessing heart failure patients, we're having to ask them, Mr. Smith, did you weigh yourself today? How much did you weigh? And track that. Now with remote devices that we can put into the home, we can blend our deviceless care management type experts with device data that's real and has a high level of integrity in the data to give our care managers more information. So I just wanted to throw that out to the audience to say, hey, how do you think of remote patient monitoring? I bet you think of it as a device, but think of it in more ways than one, because at the end of the day, it has to be monitored. And I think that's one reason it says too hard to complicate to implement and incorporate into the practice as well. So I think teaming up with companies that have the device as well as the care management to support your already busy team members is a great way to go about it. I mean,
yes. And so I think that the first and the third one are kind of very, very similar engagement, as well as a great tool for chronic conditions. But I did want to touch on that middle one, because that is that's why we exist, essentially, is so that to make it easy to bring this into the practice. So, and we've learned through the years, before RPM was even a market, that so we have to handle everything for some doctors, from recruiting the patients all the way to billing for the service. So every part in between, that we get some offices that need that. But we do have some that just say, hey, we have our own nurses, we do, our doctors will do all the recruiting, we have our own billing, we just need your devices. So it just kind of depends, but I wasn't surprised to see that hard to incorporate to be at 25%.
Awesome. So when we think about that on the tools, I mean, I know that Synsormed has a tool that you have. I don't know if you want to kind of just show a couple of screenshots of those.
I can go through a quick demo. I do know we have 2 questions left and a little time, so I'll kind of give an idea of what our mobile app looks like.
Yeah, and how easy is it for the patient?
Great. And so this is Android and iOS compatible. The code is automatically saved for them to log in. They simply click next, and there's a big begin button. They choose begin, and this is the education module that's configurable by the nurses, and they're able to click on a big button and view whatever documents that were uploaded by the nurse. So this is fully customizable, and they can choose, hypertension information, diabetes information, obesity, or what have you. After they finish the education, they actually have a COPD questionnaire, where it's really easy, big buttons, yes or no. Did you walk outside? Did you use your inhaler? Did you have chest tightness, wheezing? So all of those questions, then I'll show you in a second, we quantify those. Here we have our social needs screen that allow you to, it looks at your location, and it'll also, it asks you, do you have a lack of food? So if you click yes, it searches within the 10-mile radius of your phone's location, and it'll give you, I'm in Roswell apparently, so, and show the different food pantries in your area. And likewise, if you have trouble with transportation, you can click yes, and it'll show medical transport in your area. So this kind of helps those 2 SGOH factors. And that's it. So literally, as you see big buttons, patients get in, get out. It's really straightforward for them to send. I want to go, let me stop that share, and I'll share. So what does this look like on the other side?
That's exactly what I was going to ask you. What does the clinician see, and how do they manage that
So on the
data coming in?
side, they have their list of patients that they can search through. So that particular patient I just answered the questions for was this test patient here. I'm able to click on the graph, and this fictional patient, we're monitoring blood pressure, glucose. So I can click on the glucose numbers and see what the glucose has been over time, over the past week, day, month, year. or their oxygen saturation. I can click there and see what their numbers have been, or I can see what their surveys have been like. So this is, for example, this is the survey I just answered here, and I can get more detail. And based on the way they answered the question, it could be a positive result or negative. So did you walk outside today? No, they didn't. So they only said two things in the affirmative in a good way, that they did use their inhaler, and they do not have chest tightness today. So this quantifies it and gives somewhat of a risk score that allows you to trend and show if the risk is increasing or decreasing for that particular patient based on how they answered the questions. So
Awesome.
yeah. So, but that's the quick demo to show this is where it ends up, and the nurses are able to go in here and see, oh, they've been doing good with their blood pressure, not their glucose, oxygen, weight, so forth and so on.
Mm-hmm. And that's critical for follow-up care and making sure that patients are getting what they need after the visit. So we only have a couple of minutes, and so before we launch another poll question, I really thought it'd be important to see if there are any questions out there that have come into the chat. Phoebe, I think you were monitoring the chat if anything has come through or any
No
questions.
questions in chat for our panelists at this time.
Okay, awesome. So I do, just one quick question. What feedback are you all getting from clinicians around the tools that they're using for monitoring post-visit? Just if you could say it in 30 seconds.
Well, so the questions we're getting about quality of the devices, one, and also responsibility. So if there's something wrong, what are the protocols to make sure things get escalated correctly? So those are the two big questions.
Awesome. Ben, what about you? What do you hear from your
Well, we're an extension of their team, so they typically are contracting with us to do it for them as an extension of the team, as they, maybe don't want to change workflows that have been, are refined continuously, and scale these programs faster. So they can lean on us to do that management part of it. Working in incident too. Fortunately, most of these, from a regulatory standpoint, the regulatory environment has eased to allow more incident to work.
That's great. Well, there's not going to be enough time, and I really appreciate both of you all sharing what you're doing, what you're seeing out there, and what some of the options are for helping providers with equitable care and post-visit follow-ups, et cetera. So, and we know that everything the clinicians do is very personalized, and health equity is really achieved when every person has an opportunity to attain his or her full health. And that's, again, often, as we see, outside of the medical environment. So we thank you guys very much. And attendees, thank you for your time. If you have any questions that come up, feel free to put them in the other chat. Just make mention of this session, and we'll make sure to get back with you on those. So I will end there, and I really appreciate it. I don't know if there's anything else we need to do, but again, thanks so much.
All right, thank you.
Thank you. Have a great day.
You all as well.